Okay, good afternoon, everyone. Thank you, Unni and Shane, for this opportunity. So I will start with what are the features of pachychoroid diseases. So most of these patients, they have either a diffuse or focal thickening of the choroid, but this is not seen in all the patients. Not all patients with pachychoroid will be having a choroidal thickening. So choroidal thickening is not one of the defining features of pachychoroid diseases. So what is the most characteristic feature of pachychoroid disease is the presence of pachy vessels, which are the dilated choroidal veins in the Howler's layer. So you can make out these pachy vessels in the cross-sectional OCT scans as the large hypoechoic areas in the outer choroid, as well as you can also make out these vessels in the ICG. And another important feature of pachychoroid is the attenuation of the inner choroid, and this is as a result of the choriocapillaris ischemia. So this can also be made out with the help of OCD angio. An OCD angio, choriocapillaris ischemia is seen as flow devoid areas. And pachychoroid also shows an important feature of choroidal hyperpermeability on ICG. And this is also a result of choroidal ischemia, choriocapillaris ischemia. So in the initial phase of the ICG, these areas are seen as hypofluorescent areas, and towards the late phase, these ischemic choriocapillaries, they start leaking, leading to choroidal vascular hyperpermeability. But this is one feature of pachychoroid that can disappear in the late stage of the disease. As the disease progresses, the choriocapillaris atrophy sets in, and once the choriocapillaris atrophy sets in, then you will not be able to see this feature of choroidal vascular hyperpermeability. And if you have access to ultra wide field ICG, you can also make out an important feature of pachychoroid, that they will be having dilated congested vortex veins, which might be involving one quadrant or more quadrants. And in addition to that, you will be able to see intervortex vein anastomosis. So I'll now come to the pachychoroid disease spectrum. So basically, this pachychoroid disease spectrum can be classified into three types. The first type is where you have a normal RP with no fluid. Second type is where you have abnormal RP with no fluid. And third is where abnormal RP with the presence of fluid. The conditions which are associated with normal RP and no fluid are pachydrusen, pachyvitaliform maculopathy, and uncomplicated pachychoroid. Conditions with abnormal RP and no fluid are pachychoroid pigment epithelopathy and pachychoroid geographic atrophy. And pachychoroid with abnormal RP and fluid, this is what we usually come across in our day-to-day practice. The most common is central serous retinopathy. In addition to that, the patient can have pachychoroid neovasculopathy, PCV, peripapillary pachychoroid syndrome, and also peripheral exudative hemorrhagic chorioretinopathy. So we look at the patients who look at the pachychoroid with normal RP and no fluid. So initially, some of the patients, they will be having only a pachychoroid. There will not be any pigmentary changes. There will not be any fluid, and this is called as the uncomplicated pachychoroid. So this patient, they just require observation, and subsequently, over a period of time, the patient can develop features of other pachychoroid diseases. Pachydrusen is where you see a drusen in a pachychoroid. So what is the difference between a pachydrusen and a drusen that we usually see in neovascular AMD is that pachydrusen, these are usually seen isolated and located mainly in the peripapillary areas. Whereas the soft drusen that we see is mostly located in the macula, and they can also be associated with a ill-defined margin. And so pachydrusen, when you make out pachydrusen, often it is seen over a pachy vessel in the cross-sectional OCT scan. So what is the importance of pachytrusen is that pachytrusen is considered as an incidental finding in many of the pachychoroid diseases. So a patient with a PCV, patient with a PPE, patient with a PNV, all these patients you can have pachytrusen. But there are also few reports which say that pachytrusen, these patients, they may progress into a case of polypoidal choroidal vasculopathy. Pachychoroid vitaliform maculopathy. This is just like any other acquired vitaliform lesions. We know that vitaliform lesions can be adult congenital, which is typically is best disease, and there can also be acquired vitaliform maculopathy. So acquired vitaliform maculopathy in a pachychoroid is called a pachychoroid vitaliform maculopathy, and this results as a result of the choriocapillaris ischemia, which indirectly affects the RP function, and RP dysfunction leads to improper phagocytosis of the outer segments of the photoreceptors. As a result of this vitaliform deposit, it accumulates between the RP and the outer photoreceptor layer. And the importance of identifying pachychoroid vitaliform maculopathy is that this condition is having a high risk of progression to RP atrophy. Now let us look at the conditions of pachychoroid with abnormal RP and no fluid. the most important of which is pachychoroid pigment epitheliopathy, and this has to be differentiated from the pigmentary changes that we find in CSR. So this is not an after effect of CSR, this is something which precedes CSR. So it is actually considered as a form first of central serous retinopathy. So you should not confuse the gravitational tracts that we see in central serous retinopathy or chronic central serous retinopathy with pachychoroid pigment epitheliopathy. So often it is seen in the fellow eyes of patients who are having central serous choroidal retinopathy. Here again you can see the feature of choroidal hyperpermeability. And what are the features of the pigmentary changes that we see in PP? So it can be either a thickening of the retinal pigment epithelium, or there can be a hyperreflective RP spike, or there can be a pigment epithelial detachment. So all these findings in the presence of a pachychoroid, you can consider it as a pachychoroid pigment epitheliopathy. So what is the importance of pachychoroid pigment epitheliopathy is that there is a high chance for pachychoroid pigment epitheliopathy to progress into central serous retinopathy. So what are the features which tell you that this patient may progress into central serous retinopathy is that if you look at the subfoveal choroidal thickness, if it is more than 300 microns, or if there is choroidal hyperpermeability, then these patients are likely to develop a central serous choroidal retinopathy. The chance of this condition progressing into PCV or even PNV is very less. The pachychoroid geographic atrophy is where you see a geographic atrophy in a pachychoroid. And what the importance is that this is seen in the absence of typical drusens or pseudodrusens, which are seen in the neovascular AMD related geographic atrophy. The importance is that it has got a very slow progression compared to the conventional geographic atrophy. Now, pachychoroid with abnormal RP and fluid. We'll start with pachychoroid neovasculopathy. With this, how will you differentiate this from other neovasculopathies? That this is a neovascular type 1 neovascular membrane that you see in a patient with a pachychoroid. It is unlike neovascular AMD, it is not associated with a soft drusen. Most of the time, it may be associated with pachydrusen. And these patients will be having a flat irregular PED to begin with, or sometimes they can also progress to develop a fibrovascular PED. So most important diagnosis, most important investigation that helps us to diagnose a pachychoroid neovasculopathy is the OCT angio. So when you look at the OCT angio, you will be able to see that the fat irregular PED is harboring a tangled vascular network. And as the patient develops symptoms or there is subretinal fluid or hemorrhage, then we start treating the patients with the anti-VEGF agents. Then in addition to anti-VEGF agents, since this is a pachychoroid disease, patients may also benefit by a combination with PDT, because when you combine PDT with anti-VEGF agents, the chance of recurrence is very less. Now, pachychoroid, polypoidal choroidal vasculopathy, see it can occur even in non-pachychoroid eyes. So what we see in a pachychoroid is called a pachychoroid polypoidal choroidal vasculopathy, is also known as pachychoroidal aneurysmal type 1 neovascularization. And the characteristic features are on OCT. You may be able to see those thumb-shaped PEDs with a double layer sign. And the important investigation that helps us to diagnose a PCV is ICG, and OCT angio will show the vascular network. The aneurysms may not be made out on OCT angio. And PEHCR, or peripheral exudative hemorrhagic choroidal retinopathy, is a type of peripheral PCV where you have the choroid is thickened in the temporal aspect. You will be able to see the polyps on ICG. Then treatment is again laser and anti-VEGF injections. The central serous choroidal retinopathy is the most common pachychoroid disease that we see. It can be basically three types: acute, chronic, and atypical. And the prognosis is not very good in chronic and atypical. And acute is where you see the thickened choroid along with the smokestack or ring blot leakage on fluorescein angiogram. There will not be much of pigmentary changes, but when it progresses to chronic CSR, that is when the duration is more than 3 to 6 months, you will have pigmentary changes, and this is in fact considered as a sick RP syndrome, and you will be able to find intraretinal fluid in patients with chronic CSR. And choroidal hyperpermeability on ICG will be seen. Fluorescein angiogram will show this transmitted fluorescence along with points of leakage. This leakage points, when it is extrafoveal, we can do it, treat it with laser. And one important finding is that the chronic CSR patients can also have neovascular membrane. This should not be considered with pachychoroid neovasculopathy. So this again, you'll be seeing the fibrovascular, this flat irregular PED, and this was also mostly picked with the OCT angio. When you see a patient with OCT, this FIPD in a CSCR, and you diagnose a neovascular membrane, these patients require treatment with anti-VEGF. But one important thing is that you should also get a fluorescein angiogram or ICG done along with that, just to make sure that the fluid is not coming only from the CNVM, there could be a contribution from the CSR component also. So you treat the patient with anti-VEGF injection, and you also treat the CSR component with laser or PDT. A typical CSR, this is where you have, this is most commonly seen when the patient is on steroids, and they can have multiple areas of leakage, and often the patient presents with bullous retinal detachment. Treatment again here is with the laser, and in cases where it is not responding to laser, you can give eplerenone, and or very rarely the patient may end up with surgery like a pars vitrectomy, or sometimes even the kind of surgery that we do in idiopathic uveitic effusion syndrome, where you create a scleral window with sclerostomies, may also work in these patients. A peripapillary pachychoroid syndrome, again, this is not a very common condition. The difference here is that there's only focal thickening of the choroid in the peripapillary area. And yes, this is the last slide. So this can be treated with PDT. This is one patient where the treatment was done with PDT following with a resolution, but the patient had a recurrence, which was subsequently treated with the aflibercept injection, and again the patient had a recurrence. So we don't know actually what actually works in patients with peripapillary pachychoroid syndrome. So to summarize, it is important to understand pachychoroid diseases, and we have to differentiate it from similar conditions in pachychoroid diseases. And when you're treating this patient, they require stronger anti-VEGF injections and sometimes even combination treatment. Thank you.
Thank you, Rajesh. That was an excellent talk. Could I have just one quick question, please? Could you give any clues how to differentiate a secondary CNVM in a CSR versus a PNV or a pachychoroid neovasculopathy?
That is a pachychoroid neovasculopathy. It actually occurs in eye without a preceding history of CSR. And secondary CNVM in a CSR, this basically looks same only. Both conditions you can have a flat irregular PED. But in a patient with a central cerebral, already features of central serous retinopathy usually seen in chronic CSR. If you have you see the findings of chronic CSR in the patient along with a flat irregular PED, which shows an neovascular membrane OCT angio, then that is more in favor of a secondary CNV.